Hi, I'm Dr. Randy Martin with Northwestern Medicine's Bloom Cardiovascular Institute. And you know, atrial fibrillation is a major problem. Lots of morbidity and mortality associated with it. It's going to increase in the future. And so to look at that and to look at new therapies, Northwestern Medicine has developed the CAST-AF meeting, which is Catheter and Surgical Therapies for AFib. And at this meeting, they've had just an incredible faculty, but one of the co-directors is Dr. Jim Cox. Jim, good to see you. Jim is well known to many of you, I'm sure. Jim is not only a professor of cardiac surgery, but the surgical director of the Center for Heart Rhythm Disorder. You're so famous, the jets are flying over back here with the air shows are coming through, just to give you a flyby.
They may be coming after us.
After you. So, Jim, AFib really is a tremendous problem, and you're famous for the Cox-Maze procedure. How'd you come up with this idea? I mean, it's a wild idea.
Well, I've been asked that question a lot of times in the past, that I've told people that it didn't come out of thin air. You know, for about 15 years or more before we decided to tackle atrial fibrillation, we had been doing surgery for other types of arrhythmias.
Right.
As you know, the WPW syndrome, AV node reentry tachycardia, ventricular tachycardia, both ischemic and non-ischemic, automatic atrial tachycardias. So really, when we started on atrial flutter fib, that was the only clinically significant arrhythmia that we hadn't tackled. And the reason we hadn't is it was obviously a lot more complex.
Did you get, you know, the times were very different then than they are now.
Yes.
And not only since my early days of training back in the 60s and 70s at Stanford, the surgeons, you know, had tremendous technology and stuff. Did you get pushback from your colleagues about doing, or the non-surgical colleagues about going in and slicing and dicing the left atrium?
Oh, me. I got a lot of pushback.
I bet.
And not just from my colleagues I was at Duke University, not only initially, not only my colleagues there, but the colleagues elsewhere. And when I try to present this, when we finally developed a reasonable approach, I was at Washington University in St. Louis, and of the first 100 patients I did, only one patient was referred from Washington University.
Interesting.
So they were very conservative. But then once, you know, it took some time and went through the usual stages and so on, and then I received absolutely fantastic support from all of them.
It's interesting that you've got not only obviously expertise and foresight and knowledge, but you have also now the years of experience looking back on it. What's been the most important thing that you've learned for the surgical maze approach as you think, looking back at your 20+ years experience with it?
Well, you know, the way I did it initially in the first few patients, and I might add that Pat McCarthy, who's the head of the Bloom Cardiovascular Institute here, who's my boss now, Pat McCarthy was the only other surgeon in the United States, or the world for that matter, who came to St. Louis to learn how to do this. And every time I did a case, he would come. And so there was a time in the early 90s when we were the only two surgeons in the world doing this.
Interesting.
So, but what we were doing at that time was a much, much bigger open heart operation than what's done now. So I think that the best thing that's happened in the last 30 years since we first started this is that it's been constantly improved, constantly simplified. Industry got involved in it in a heavy way in the late 90s. So we now have devices that allow us to do the same operation that Pat and I used to do in a quarter or a third the time. And to show you how circles close, Pat's presentation during this course, his major presentation during this course, was about a further improvement in this that I think is going to be extremely important because it cuts the present procedure down by at least half the time. Cool. So we sort of come full circle. So I think the progressive improvement in the device, its application by others, even the catheter ablation people use basically those principles and so on. So I think that's the most important.
Let me go back, because I started to ask you this before, because I think I'm always intrigued by people who are at the forefront of developing technology and withstand the naysayers. So you knew that the surgical approach, you knew it was needed, but the surgical approach would be successful? Was that based upon animal work and other work?
Yeah, by the time we did it the first time in a patient, I was absolutely certain it was going to work. But I don't know if I can say this on television, but I've said many times in public that developing the Maze procedure is a little bit like having babies. You can't do it by yourself. And I did not do this by myself.
I understand.
I had a lot of the world's greatest electrophysiologists, both at Duke and at Washington University. And what I learned from them about the definition of what the real problem was allowed me as a surgeon to say, I know how to fix that. And then we studied it in animal models and tried it and so on and so forth. So by the time we did our first patient, after all those years of research, I knew it was going to work.
So that theme is really what you've accomplished at this meeting, getting electrophysiologists and cardiac surgeons in this field together.
Yes.
So Jim, tell me just briefly, what's the Cox-Maze for? I mean, for the audience that might not know. In other words, this lesion set you've evolved to, what is it?
Well, the lesion set of the 4 and the 3 are the same.
Okay.
The lesions are just put in a different way.
Okay.
So we may end up having to call it the 5 with this when Dr. McCarthy is doing now, because the lesion pattern is the same.
Okay.
It's just using new devices, you can do it much quicker, and by thinking it through a little bit and so on. I think that the lesion pattern has changed.
Okay.
And there are basically 3 fundamental lesion patterns.
Okay.
And they evolved, if you have a Maze 3, that means you had a Maze 1 and a Maze 2. There was something wrong with it. So when we'd done about 35 patients in the Maze 1, we found a couple of problems. They weren't prohibitive, but they were serious enough that we knew we needed to change something. So we made some alterations in it and to what we call the Maze 2. But those alterations made the operation so technically difficult that it was almost impossible to do. So I just abandoned that one after about a dozen patients and went to the Maze 3, and that was has sort of been the stable since the early 90s. About 2002, about 10 years later, Ralph Damiano, who's now in my old position in St. Louis, Ralph made I think a significant advance and called it the Maze 4. And the advance was that he used a combination of radiofrequency clamps and cryosurgical devices and so on to make it shorter and simpler, and then showed that it got the same results and so on. What Patrick's done now is the lesion pattern's the same, but the device, not just the devices, we've used just cryosurgery for a long time, but the way he's using it, he's figured out a way of, instead of having 7 linear lesions in the left atrium, for example, he can do it in 3. He creates all the 7 lesions, but with 3 applications, which cuts the time, that the heart stopped in half the time. So these have all been incremental steps, including the ones I had early, and then Ralph and Pat. But I think that's been probably the thing that's been most satisfying to me. 2 things. Seeing it improved on by my colleagues and people I've known years later, for years. The second thing that I'm pleased with is that the first patient we did just as well as the last patient we did. And it gets back to your original question, did I know it was going to work? Yeah, I knew it was going to work. And that's very pleasing, because that first patient and the second patient and third did just as well as the patients are doing now. You told
me something interesting just before we came on the air, is that you have 2 of your patients are actually at this meeting listening to it.
Yeah, I have. I won't say who they are because it's a public thing, but one of the patients is the only patient I'd ever operated on personally for any kind of heart operation, who was a personal friend of mine. So I knew him, quite some time before I actually operated on him. And the other one is a physician. And so the reason I had them come here is that this has been going on now for so long that I think a lot of well, since we're having all the electrophysiologists here, I thought maybe we ought to be sure they understand. So I brought these two guys here, and one of them is 24 years post-op.
Goodness.
And the other one is 27 years post-op. They're both very successful professional men, and they've both become friends of mine over the years. And every June 6th for the 27-year guy and April 19th for the 24-year guy, I get a call. Hey, it's anniversary. You know? And I ask, what year is it? That's why I know how long it's been.
That's fabulous. Well, congratulations on this meeting, but most of all for making a really major contribution, I think, to helping patients, you know, in general and patients with AFib. So thanks a lot for that.
Thank you very much, Randy.
And thank you for joining us. You're going to want to stay tuned because we've got a lot more really breaking information on atrial fib that you're going to find very useful.